Okay, guys. Hi, I hope you're well. Thank you so much to the BUDRC for the invitation. Thanks to Samaya and Sabina for being fantastic in trying to get me here. So I hope you guys have had a great morning. It's a lovely day outside, so we can go and get our exercise very, very soon. I was asked to talk about something called the restorative intervention, from prevention all the way through to restoration. What does that mean? Well, basically, under all circumstances, we're always going to do what's in the best interest of the patient. And I think in today's day and age, where things may be considered as elective, non-elective, whatever, we need to just be putting the patient at the beginning of all of that. So hopefully, I'll try and discuss what my restorative workflows are within a very short space of time. We're running behind, so I'll try and be as efficient as I can. And there will be a little small discussion at the end about sort of aesthetic or sort of non-restorative driven plans that might be there to improve aesthetics. So I think what's really important to sort of say is that we're here to try and do as best as we can for a patient. We're trying to minimally intervene under all circumstances. I just want to say a quick thank you again to BUDRC Sculpt, which is an organisation that I'm part of, that are providing hands-on training for clinicians all around the world, actually, and Colgate, who've been supporting me for a long time now. All the photography that you see is my own work. This is the current practice I work at, so it's Wimpole Street. It's number 28, LCI80. I work at 11 Dental, which is also in Devonshire Place. And I'm very fortunate to work in practice in Chelsea. So I'm very, very delighted to work where I do. I undertook a master's in restorative dentistry, was at the University of Birmingham, so I was delighted to have completed that. A lot of work, actually, but I've been invited back as a lecturer and an examiner for the programme. I've won some awards that, I mean, they make a nice slide. What do they mean in the scheme of things? They're not they are peer reviewed, actually. They are actually peer reviewed. But yeah, it's just something to remain within the sort of context of the dental industry, I suppose. I've done some publications, some peer reviewed, some non-peer reviewed. But for those that know or follow me, I've obviously done a few lectures in my time. But I was also traveled a lot to Italy to learn from these absolute sort of legends in dentistry, really. The chap on the right-hand side is Walter Devoto. On the left, you've got Anna Salat and Jordi Manrauta, and that's obviously my wife behind. Lovely food, obviously, but also amazing education. So there's something called the ICDAS system, which is the International Caries Detection and Assessment System. And it's a fantastic system, really, that allows you to understand the sort of visible progression of decay. So what I thought to do is to show you this so that we can base the way that we intervene accordingly, right? So let's talk about phase one. So if you've got an ICDAS 1 or 2, which is just visual distinct changes in the enamel, what are we going to do? Well, what we're going to do is prevent any progression of the caries, right? So Durafat varnish is a fantastic tool that really allows for reduction of progression of any tooth decay. And Manrino and colleagues have really demonstrated this in adults, in children and adolescents, but also it's very, very applicable to adults. So what we want to try and show is that we're trying to prevent things getting worse. We're not in a situation where we're going to wait for things to get worse before we treat them. We want to try and prevent them from the start. So there's multiple topical mechanisms. Varnish is one, but also Durafat toothpaste, which is important. This is for children over 10 years old. And the sodium fluoride that's in it also has been shown by Bierstock and colleagues to reduce DMFS, which is decayed, missing and filled teeth, by 20%. So it clearly works. Then we've got Colgate Durafat, 5,000 parts per million, which is for 16 and above. And I mean, this is something that is my workhorse in practice. You know, if we're seeing new patients and there's early tooth decay, interproximal decay that's not progressed to the dentine, I'm always going to give it the chance. Now, ultimately, usually it's multifactorial. So it's dietary sugar, dietary acid, oral hygiene mechanisms. And if only one of them is sort of attempted to improve the outcome, it doesn't really work. So they need to be on side with oral hygiene. They need to be seeing the hygienists. They need to make dietary modifications that allied to a topical fluoride application through toothpaste can massively improve things. But the really fantastic piece of evidence is this about 76% reversal in root caries. So particularly in those that have a lot of recession or particularly older patients. You might notice that the roots are exposed a lot more, and these are more susceptible to tooth decay. And this 5,000 parts per million varnish is shown to work really, really well. And for those that know restoratively, bonding to root dentine isn't always the most straightforward. So if we can prevent it progressing, always. That's the way for me in restorative dentistry. So ICNAS3, this is when we're starting to think about preventative resin restorations, and McConaughey and colleagues have documented this a long time ago in 1992 about the effectiveness of the PRR. And what we do is basically we will do either a fissurectomy with a burr, which is traditional, but or more importantly, recently we're using aerabrasion techniques to try and reduce the or improve bonding, but open up any small areas as minimally as possible that may have had decay progression. But you can also use, on the right-hand side, you can use ultrasonic tips, which are really, really fantastic. So then we get to ICDAS4 and beyond, really, because this is where you're probably going to restore. Now, also, just going backwards, in ICDAS3, if it's just bleached your enamel, sometimes you might actually be required to do a small composite restoration. But from 4 onwards, more likely, you're probably going to have to restore. And I'd be quite open in saying that composites are probably the major stay of my dentistry. In fact, posterior composites probably make up 50% of my workflow in my week. So it's something that we need to work on. Adhesion is important. We have to understand it, and also isolation. So talking on isolation, I thought would be a good way to just discuss rubber dam. And there's lots of evidence out there, okay? Because we're the undergraduate research conference, I want to sort of bring evidence to your front of mind. And evidence, we have to be very, very careful on evidence, as we know. There's a hierarchy of evidence, and a lot of these papers are usually case reports, or at maximum, they might be a case series. Because actually, there's one truth about research in dentistry, which is always difficult to manage, and that's to try and, firstly, ethical approval. You can't do something knowing that something's going to have an adverse outcome. So that's difficult to do. But also trying to have just the logistics of having a dentist with the same group of patients and following them over 5, 10, 15 years is very, very difficult to do. People move, people change life, people change jobs. So sometimes it can be quite difficult. Retrospective studies are fantastic. And Trevor Burke, one of my professors at Birmingham, has done a fantastic paper by the Dental Practice Board Network, which is retrospective data for the last 20 years, actually, so worthwhile knowing. But going back to rubber dam, people talk about why rubber dam is a fantastic tool and how it can improve outcomes. There's a fantastic paper by Casagera in 2014, which turned around and said, do you know what? Rubber dam's a fantastic tool, but there is no statistically significant improvement of outcomes, irrespective of the method of isolation that you use. So what they're trying to, what this actually, and this was one of the first papers for me that I read that said, oh, this is actually quite clear. It's not that you need rubber dam, it's that you need isolation. And that could be cotton wool rolls, that could be high speed suction, whatever. For me, rubber dam makes life easier, and I'll talk about that shortly. So Wang and colleagues in 2012, actually I found this afterwards, strangely, did a Cochrane review. Yeah, so Cochrane systematic review, highest, pretty much the highest on the evidence tree. What did they find? Well, all of this, I think there were 75 papers. They could only include 4 because of the inclusion criteria, of which they were all high risk of bias. And there was no clear improvement of outcomes with rubber dam over things like cotton wool roll. So, you know, while very, very a proactive user of rubber dam, and I think you guys as undergrads and potentially when you get into practice, should you definitely practice the skill. Is it going to change your outcomes? Not necessarily. Will it reduce your stress in the long term? Absolutely. Will it make it easier for you to restore? Absolutely. So therefore, there's other reasons why you might consider using rubber dam. And these are just the proposed benefits here. But obviously, there's a lot of perceived barriers to why you'd use rubber dam. And a lot of them are to do with, you know, for instance, lack of understanding, lack of training, lack of knowledge, no real need because no one's had debonds or failures of restorations prematurely. Incidentally, this is a cracking paper by Bergen and colleagues. It's a Swedish group in 1997, which showed that actually if you put rubber dam on, they did fissurectomies in patients in the right quadrant and the left quadrant, including some very, very specific inclusion criteria. And the side that they used the rubber dam, they found that the patients perceived less pain Very interesting. They had, electrodes and finger on the fingers to measure pulse, but they also had breathing, etc. And there was an increase in perceived pain if Ramadan wasn't on, incidentally, which is also quite an interesting point. Okay, so let's just show you actual clinical work, because obviously it's important to talk about evidence, but realistically, what are we doing? How are we applying that into clinics? That's what's really, really important for me as a practicing clinician. You've got caries, okay? So what are we going to do? What is that? That's probably ICDAS 4, 5, because there's visual shadowing of the enamel. You start opening the cavity, and obviously you start noticing how deep it actually goes. So when this is extremely powerful for patients. When you start cleaning the cavity, you're like, oh, it looks quite small. In fact, you can't even see a hole because it's interproximal. But that's the size of the cavity when everything's perfectly clean. We use something called a sectional matrices, which allows for us to rebuild the interproximal wall. So look at that a bit more closely. I probably could have been a bit better with trying to polish the extremity of the margin, but hey, we're not all perfect. And then you build the composite into that wall area. And the idea is you create a contact point almost every single time. You'll build into the dentine and your enamel in increments. You'll polish it, and that's what the restoration looks like immediate as the patient leaves. Now, they're delighted because they're going from something like that to that. Whether they need to know about secondary anatomy or tertiary anatomy, fissure staining, that's not really their bag, right? That's for us if we want to do it. But realistically, if you can get a conformative restoration, that's what matters. And posterior composites form a big part of what I do day to day. It's like I said, it's the main workhorse, because actually most people, the majority of treatment that you're going to be doing really is fillings by and large. So it's a skill that you need to learn. Here's another case that I did with DMG's composite, which is called Echosite Elements. The patient had lots of decay under her existing filling. We were able to replace it with a natural looking restoration. Does she care that there's secondary anatomy? Absolutely not. Does she care about the fissure staining? No, because it's almost minimal and it's on her adjacent teeth. All she cares about is, have I got pain? Is it comfortable? If the answers are yes to those things, you're a winner to the patient. So just be clear that even if you do like doing these things, that's totally fine. It's for you, and that's all right. We should have some professional pride in what we do at practice. So when it starts getting quite big, ICDAS 5, 6, when there's big parts of cavities or big corners of teeth breaking off, we need to start considering indirect restoration. Now, indirect principles are really, really important to understand, because actually Langland and Langland in 1965 did this study about teeth that are crowned. It's a very, very prominent paper. And what do they find? 1 in 5 teeth develop pulpitis. This is very, very common knowledge. I think all of you guys should know all of this. So, right, a crown is something where we will circumferentially prepare a tooth and create a hat that goes over the tooth. Do we need to do that for all teeth that have had a corner of a tooth break off? No. Can we do it direct? Yeah, possibly. But if we're going to provide some occlusal coverage, what are the options? And this is where the indirect only principle comes into play. This is a really, really important development in dentistry, and it's been around for a flipping long time, actually, because the preparation technique I'm showing you, this is for gold. So this has been a long time here, for a long before adhesion was as predictable as it is. But basically what you need to do is get at least 1 millimeter for gold. You need at least 1 millimeter occlusal reduction, particularly on the functional cusp. You need a bevel. You need to round the interproximal line, the internal line angles. And if you have an isthmus, so that's the center sort of channel within the tooth where a previous amalgam was, for example, it needs to be a minimum of 1 to 1.5 millimeters. That's for the rigidity of the material more than anything. Now, when we're doing lithium disilicate, or some people know it as EMEX, the proportions change slightly. So the isthmus width needs to be wider, which is 1.5 to 2 millimeters on average. The functional cusp bevel, so the thickness occlusally, you need to have at least 1.5 millimeters occlusal clearance, but you still need to round the internal line angles. So what I'm trying to say by all of this is all good and well doing crowns, but actually if there's an opportunity to preserve the tooth as much as possible, because of current adhesion, I'm very, very comfortable trying to do onlays on a regular basis. And there's another fantastic paper by Veziani in 2017, which is called the morphological driven preparation technique. This is more of a case studies or series rather than a randomized controlled trial of any nature. But what the principle of it is absolutely incredible, which is you maintain, and you should be doing this for your onlays, crowns anyway, you maintain the shape of the tooth, or you do the reduction in accordance to the cusp height. It's not just a flat reduction. And you will get very, very well fitting restorations that also have an element of retention form, resistance form, but more importantly, will be able to be luted or adhered when they're cemented very, very easily. So I thought I'd just show you a workflow. When you've got a patient who's had a root treatment, I isolate to do the prep because it just makes my life easier. You'll obviously prepare the tooth, clear the interproximal contacts if you need to, take an impression, get a model made, try it on, cement in. So that's by and large. I had a lot more information on this, but I have to just cover as much as I can in restorative in 20 minutes. I'm working, girls, I'm working. But someone asked me, is there like a formula for indirect onlays? And the point is, it's not. There's not a formula. Each tooth, each cavity, in a way, you know, people say, oh, what's the formula for doing an ideal occlusal cavity? What's like, remove the caries. That's the ideal way. So when you do onlay preparations, when you do, it all depends on how much tooth structure is there and how much is compromised. Sometimes you'll do a core, sometimes you won't. We can't get into the core debate today, but some people believe that actually by adding a core, you increase the interfaces, it can increase stress. I don't believe in that, but I can talk to you more about that. But by and large, where possible, I will always try and finish margins on sound tooth, always. So obviously, if it gets beyond that, we need to do root canal treatment. So root canal treatment is the process of cleaning out where the nerve canal is, making sure you remove any sort of infection or debris that might be organic and contribute to infection. And obviously, we can leave ourselves with a reasonably good access. Okay, access is key. Straight line access is key, and I would say that even though I love doing adhesive dentistry really and elective, or a bit of orthodontics, a bit of cosmetic stuff, I still am not going to de-skill it in things like endodontics, because at the end of the day, if a patient comes to you to be treated and you just do, for example, I do clear aligners only, yeah, but I've got pulpitis, are you going to be worried about doing that extirpation? You shouldn't be at all, and that's totally fine if you're going to be an aesthetic dentist or whatever. I don't believe in that term, frankly. I believe that we are all aesthetic restorative dentists, and that's what we should be. Obviously, when you start getting further and teeth need to be lost because the caries is unrestorable, we can start doing implant restorations. Okay, I've got a case here that was a multi-interdisciplinary prosthodontic. So this was a 4-unit bridge, 2-to-2, and the both laterals are root treated. So this just goes to show. I mean, everyone says that you shouldn't do this, and we all know that this shouldn't be done. This has lasted 10 years. So the margins were starting to show, and actually there was a little bit of food packing around the bridge margins. So I was like, right, actually, I'm not comfortable restoring this again with the bridge, even though yours has worked really well. Why don't we consider replacement of the missing tooth with an implant? And that's what we got to. So the patient was delighted. We only replaced 4 teeth. He was happy, even though there's a slight shade discrepancy between the anterior and canines posteriorly. In fact, even me, I've got a discrepancy from the canines, but he was over the moon. He was just delighted to get, teeth that looked like teeth, that were individual teeth that he could floss. But of course, we are dealing with an aging population, and there are going to be more people that present like this, which are grossly restored, grossly fractured tooth surface loss. Every time that a dentist does a composite, it all chips. Well, obviously, because he's pseudo class 3 edge to edge, his muscles have not been deprogrammed, so he's going to be squeezing on everything that he can. And we do some quite in-depth analysis with digital smile design. We do a lot of trial restorations, wax ups, provisionalization, ensuring we've got good guidance, and then we restore the teeth. So the patient comes in like this and he leaves like that. So obviously it gives the patients the understanding to, the opportunity to have some sort of confidence. I love this photo. This is from my master's, incidentally. I love this photo because they were like, did you actually put a TV between every tooth? I was like, yeah, I did, because they were all interproximally cleansable. And that's the key. When you're doing composite restorations, that interproximal area is absolutely critical to the longevity, as well as occlusion, but critical to the longevity, because we don't want to get secondary caries interproximally. And there's a close-up. So just to finish, I'm not doing too bad for time, girls. Look at that. I just wanted to quickly talk about elective dentistry. So we will see patients. This is a patient who turned up with a devitalized central that's been root treated. She had whitening before. She didn't believe me that it was going to work. I said, look, she came to me for a veneer. She'd researched me through various avenues. And I said, look, a veneer is not the ideal. For those that know restoratively, to try and mask that cervical area, you'll have to prep 1.5 millimeters probably to get sufficient thickness of your material so that you can mask it. By that point, you've lost all your enamel anyway. So preparation challenges are really, really important with these cases. So even if I was going to do a veneer, I'd whiten anyway. And this is with internal external whitening. So just have a look at that before and after. I haven't restored the tooth at all. This is very well documented by Greenwall, Cohen, and Greenwall in 2019 about the internal external white bleaching technique, which is closed. So you seal the gel in and you top up from buccal and palatal. Fantastic technique. Worked very well with me. I do a lot of resin infiltration, which obviously is for removal of these white spots. So the patient attends with these white spots. The only other option they've been given is a composite veneer, which means complete surface area etching, which I don't believe in necessarily. So what we do is use a hydrochloric acid etch, localize the area, and we're able to remove these white spots very easily. And here's another case which was really significant hypermineralization defects across all of the upper teeth. I think it was premolar to premolar, and the left-hand side was pre and the right-hand side was post. So obviously you can get some relatively nice results with these great techniques now because adhesion is possible. Obviously composite post-ortho is something I do a lot of, but I don't necessarily believe that everyone has to have a composite veneer. So in some cases, when we're masking a canine to be a lateral, absolutely you need to cover the full occlusal surface, but not always. So my point is, choose when you want to consider it. So here I've done a case where this patient came in and said, I want my black triangles reduced. It's very easy to suggest that we need composite veneers, and you won't believe I've only done interproximal black triangle bonding and edge bonding. I haven't veneered the teeth at all. She's done some whitening, and that's it. So you can achieve fantastic results just by respecting the biology and making sure you're doing as minimally as you can. Yes, at some points you do need to do composite veneers, and this patient had them for 10 years, and we were able to replace them and give her natural incisive edge profile and much nicer shape. And that's a close-up of it polished. And I have no problem showing close-ups because actually it should be to a point where even if there is a demarcation, it's completely smooth, so bacteria can't adhere to it. And obviously, when you consider doing indirect aesthetics, this patient has been unhappy with his crown for ages. Everyone said to him, it's fine, we don't need to do anything. Right, you don't need to do anything, but he's totally losing confidence in his smile. And we were able to get him some form of smile back with some orthodontics, whitening, and a crown. But you are going to see children that will want to run into things. Okay, so they like running into walls, they like picking fight with bollards. It's just a way of life. I had a patient, I'll show you in a minute. How did it happen? I was sliding face down a slide. It's like, well, that's asking for trouble, isn't it, really? They're totally fearless, bless them, totally fearless. But you need to be able to respect the biology and understand mechanisms to adhere. And I still do pediatric dentistry to try and restore teeth as best as you can. Yeah, sure, I didn't get the chance to polish it as much as I want. Yeah, sure, I didn't get the chance to, put the characterizations that I want. But this is real life dentistry. At the end of the day, it's very difficult sometimes to get children to adhere. So again, this is a chap that's sliding down face first. And as you can see, we're able to give him a tooth that looks like a tooth afterwards. So 21 minutes, guys, 21 minutes. I've done 90 slides. The last thing I just wanted to quickly say to you guys was there's things you might want to consider investing in as you qualify, as you get through your final years of your qualification. And for those that know, this is called a black box. The black box thinking is a process which is a book that was written based on the airline industry, where all airplanes have a black box which records everything that happens, everything, and it's driven for patient customer safety. So anything that happens on the plane, any switch that's turned, is all documented. And it's not for a blame culture, it's for safety. And I think dentistry's black box is the camera. So if you get the chance to invest in photography equipment to take photos, I mean, sure, if you have to do it within your hospital, all of the hospitals are really on board with taking photography. Just make sure you're not sharing them inappropriately, etc. Make sure you always have consent as well. But an opportunity to learn is by taking photography, and that by and large has hugely changed my career progression. Having a look at my work, being unhappy with it, trying to say, all right, I want to do this. You attract a specific way of growing if you're really criticizing yourself on a regular basis. And yeah, sure, I mean, there's great things like social media platforms now where you can push yourself as an individual, but that wouldn't be my primary cause for it. That would not be my primary cause. But clinical photography is something you can learn and enjoy. I'm so sad. I just enjoy taking photos of patients' teeth that haven't even been worked on, because it just allows me to understand what nature's created, so I can strive for my drive to get closer and closer. But you can do it through mobile photography. What I would say to you, if you are going to do that, is make sure it's on a device that's not linked to your iCloud, because there's GDPR issues with that. So people that I know that I've trained, they've got a practice-only device which is registered to practice email, and they use photos on their phone if you would like to do that. Personally, I just don't like it because I like my big setup that I've invested in, but also the quality is not quite there yet for me. But you can be experimental with your photography. Magnification, illumination, an important thing. So being able to see what you're doing is going to make it damn sight easier to prepare things in an appropriate way. And obviously invest in yourself in terms of courses. So as you can see in my background, we've got something called Sculpt, which I have created with another, actually a student from down south. And what we have created is this opportunity for people to get these kits posted home. In fact, some of you are going to be doing the hands-on anyway, which is in 2 weeks' time. For those that have written to us, don't worry, we're absolutely inundated with things. You are going to get your kits. Don't panic. We will make sure you get your kits. But we're delighted to be able to provide training on home through a Zoom platform, which has got a very, very high-tech AV setup that allows for very, very clear composite follow-on, basically. And I've done it live probably 8 times already. So I'm really delighted to be bringing that to everyone. And whatever it is that you do outside of dentistry, guys, make sure you keep doing it. We've been in lockdown, we've been in COVID. It's been a really, really tough time. And actually, all that keeps you sane are your loved ones if you're able to see them. Probably keeps you insane if you can't see them. But also the things that you've always done that are outside of what you're working for. So for me, it's totally, I mean, the only reason I agreed to Samaya and Sabino is so that I could get a suit on, because I don't really get the chance to wear them very often. But for those that know, I love fashion, I love traveling, and I've been a competitive dancer for a long time. So whatever it is that keeps you going, make sure you keep hold of that like a you know, with a really tight grip, because actually, unfortunately, times like this are not behind us yet. They might not be behind us for a while. Although there is light at the end of the tunnel, something like this could shake our lives again. So we just need to be prepared for things like that. So 23 minutes, team. Right? They sent me a message. The team sent me a message like, "Can you please run to time?" I was like, "Yeah, I know I like talking. I'll try and run to time as best as I can." I just wanted to conclude to say, if you adhere to minimally invasive principles, it's always going to be able to provide you with outcomes that are probably as optimal as can be. Topical aids and prevention is key in ensuring that you minimize the restorative cycle. But when you do need to isolate, when you do need to restore, isolate where possible and try and conform occlusally. For me, restorative dentistry, aesthetic dentistry, and functional dentistry is all exactly the same thing. So, in that whistle stop tour, I want to say a big thank you to everyone that tuned in. I want to say a big thank you to Sabina, Samaya, the whole team at Murdoch, BUDRC. You've been fantastic. I think it's great to see what you guys are doing in the current times, and I'm always here, willing and ready to support.
Okay, thank you, guys. Do you have a question for Dr. Khan? What type or brand of camera and loops do you recommend for a student to invest in?
Great question. You know, I'm very, very understanding of the fact that as students, you know, it seems like we're always paying for tuition fees and everything. So I can understand it gets quite expensive. For me, that if you're going to invest in something like loops, they're probably going to be yours for at least 10 years. So even if it is a matter of thousands of pounds, if you divide that over the amount of years that you use it, actually it starts being a lot more justifiable. The brand that I use in terms of loops is Oroscoptic always. It's the ones that I've used from the beginning. There are a lot of loops companies that are fantastic out there. For me, the reason that I chose Oroscoptic is I actually like the idea of their eye zooms. So they've got multiple magnifications on one loop. But also they offered very, very reasonable finance packages to try and pay it off, because I couldn't afford it at the time, you know. So Oroscoptic, there's a fantastic chap called Michael Reichel is his actual name, his real name, obviously. He's fantastic. He's the chap that I work with in Oroscoptic. If you need more information, you can contact him directly. Camera, you need a digital SLR of any nature, whether it's Canon or Nikon, it doesn't really matter. They're the main leaders in the run for the SLR, the best SLR. I don't think you need to be too concerned about buying the all singing, all dancing ones. You can usually buy a very entry level Canon body for about £200. You need a macro lens, which is a lens that is it's basically got a magnification ratio that allows you to see small objects in a lot of detail. 100mm macro is ideal. That's probably going to cost you about £300. And then you can get various brands of lighting. I just tended to go for Canon as well, a ring light of some nature, and that will put you in good stead to be able to take photographs of all of your work, review them, reflect on them, grow from them. Sorry, it's a long answer, but I hope that helps.
That was a perfect answer. Thank you. Another question is, how do you keep up to date with the latest protocols or the techniques during your career?
That's, I mean, one thing that you guys will all understand is that you think, I was I was once a student, 2013, I was like, I can't wait to not study anymore. And what you slowly realize is when there's no more targets or checklists to achieve, i.e. like year exams, end of year exams, finals, whatever, all of a sudden there's no more pressure anymore. And what that did for me is it opened up a doorway for me to say, well, actually, I want to take charge of my career, and I want to optimize what I can achieve afterwards. So you will be in a lifelong system of learning. Incidentally, just talking quickly about finances, if you go on courses, they're tax deductible. So actually, you pay less tax if you go on courses that are helping committing to your learning. But also, my master's did quite help me understand the basics of restorative dentistry, the understanding about what evidence was out there, how to critically appraise it. So when I read papers now, I have a good understanding of whether they're just advertorial for materials or whether they're actually reasonable studies that have got a good methodology and are giving the reader some sort of application process. But that's always supplemented by courses. So that's how I learn the actual techniques. Hope that helps.